Imagine a virus so deadly that up to 3 out of 4 infected people may not survive. A virus with no approved vaccine, no specific treatment, and the terrifying ability to jump from animals to humans and then between humans themselves. A virus that doesn't spread fast, but when it strikes, it kills silently and brutally. In January 2026, 2 confirmed cases of this virus in India triggered heightened airport screenings across Southeast Asia, including Thailand and Malaysia. That virus is Nipah. Today's video is not meant to cause panic. It is meant to create awareness, understanding, and preparedness. Because history has taught us one thing very clearly: ignoring emerging viruses early can cost millions of lives later. This is the full report on the Nipah virus: what it is, how it spreads, why experts are concerned, what the science says, and how worried we should actually be. Stay till the end. This information matters. What is Nipah virus? Nipah virus is a zoonotic virus, meaning it spreads from animals to humans. It belongs to the encephalitis genus, part of the Paramyxoviridae family, the same viral family that includes measles and mumps, but Nipah is far more lethal. The virus was first identified in 1999 during an outbreak in Malaysia, where pig farmers began developing fever, confusion, severe brain inflammation. Within weeks, many were dead. Investigators discovered the source: fruit bats, also known as flying foxes, had infected pigs. The pigs then transmitted the virus to humans. This discovery changed how the world understood animal-to-human disease transmission. How deadly is Nipah? Let's talk numbers because they are chilling. According to the World Health Organization (WHO), the case fatality rate of Nipah ranges from 40% to 75%. This depends on early detection, quality of healthcare, speed of isolation, and supportive care. To put that in perspective, COVID-19 fatality rate, num1 2%. Ebola fatality rate, num25, 50%, Nipah up to 75%. And unlike many viruses, survival does not always mean full recovery. Some survivors experience long-term neurological damage, personality changes, chronic seizures, memory loss. Nipah doesn't just kill, it can permanently damage the brain. How common is Nipah? Nipah is rare, but persistent. Since 1999, around 750 confirmed cases globally, approximately 415 deaths. Most outbreaks have occurred in Bangladesh, almost yearly. India, Malaysia, Indonesia. Why mostly South Asia? Because this region has large populations of fruit bats, close human-animal interaction, consumption of raw date palm sap, dense population clusters. Importantly, each outbreak has been small, but each outbreak has been deadly. How does Nipah spread? Animal-to-human transmission. The primary reservoir of Nipah virus is fruit bats. The most common transmission routes: eating fruit contaminated with bat saliva or urine, drinking raw date palm juice, contact with infected animals, especially bee. In Bangladesh, researchers found bats lick date palm trees at night. Their saliva contaminates the sap. Humans drink it raw the next morning. A single traditional drink becomes a deadly exposure. Human-to-human transmission. This is where concern increases. Nipah can spread between people, especially family members, healthcare workers, caregivers. Transmission occurs through close physical contact, exposure to respiratory secretions, poor infection control in hospitals. However, and this is important, Nipah does not spread easily like COVID-19 or flu. It requires close, prolonged contact, which is why outbreaks remain limited. Symptoms. Why Nipah is hard to detect. Nipah often starts silently. Early symptoms: fever, headache, muscle pain, vomiting, sore throat. These look like flu, dengue. Malaria, typhoid. Doctors may miss it in the early stage. Later symptoms: drowsiness, confusion, disorientation, seizures, difficulty breathing. Eventually leads to acute encephalitis, coma within days. This rapid progression is what makes Nipah so lethal. Why airport screening may not be enough. After the recent Indian cases, countries increased airport screening. But scientists warn this may have limited effectiveness. Why? Because Nipah has a long incubation period, 5 to 14 days, sometimes even longer. A person may feel completely normal. Past screening, become critically ill days later. This is why community surveillance is more important than border checks alone. Global pandemic potential. Should we panic? Let's be clear and responsible. Nipah is not currently a pandemic threat. It does not spread easily through air. It is not mutated to become highly transmissible. However, the WHO classifies Nipah as a priority pathogen because high fatality rate, no treatment, no vaccine. Animal reservoir difficult to control. Scientists worry not about today's Nipah, but about what it could become. Viruses evolve. Vaccines and treatment. Where does science stand? Current reality: no approved vaccine, no specific antiviral treatment. Care is supportive only. IQ care. Ventilation, seizure control, managing brain swelling. Hope on the horizon. Oxford University scientists, the same team behind the COVID-19 vaccine, are developing a Nipah vaccine. Key facts are: uses viral vector technology. Phase 2 trial started in Bangladesh, funded by CEPI. This is a major step forward, but approval will take time. Why Nipah is a public health warning. Nipah teaches us something crucial. Human encroachment into wildlife habitats increases spillover risk. Climate change alters bat migration. Deforestation brings animals closer to humans. Nipah is not just a virus, it is a warning signal. What can people do? For the public, avoid raw date palm sap, wash fruits, thoroughly avoid contact with sick animals, seek medical help early for fever plus confusion for healthcare systems, rapid isolation PPE for healthcare workers, contact tracing, public education. Awareness saves lives. The science of Nipah virus, how it attacks the body. To understand why Nipah is so deadly, we need to understand how the virus works inside the human body. Nipah virus enters the body through the nose, the mouth, or through broken skin. Once inside, it targets something extremely critical: blood vessels and the nervous system. Why this is dangerous? Nipah virus infects endothelial cells, blood vessels, causes vasculitis, inflammation and damage to blood vessels, leads to leakage, bleeding, and clot formation. When blood vessels in the brain are affected, brain swelling increases, oxygen supply decreases, brain tissue begins to die. This is why encephalitis is such a hallmark of Nipah infection. Unlike many viruses that remain localized, Nipah crosses the blood-brain barrier, directly infects neurons, triggers massive immune inflammation. In severe cases, the immune response itself contributes to brain damage. Why Nipah has such a high fatality rate? Several factors make Nipah exceptionally lethal. Rapid progression: patients may go from fever, confusion, coma in less than 72 hours. Late diagnosis: early symptoms mimic common illnesses, leading to delayed isolation, delayed supportive care. No targeted treatment. Doctors can only support breathing, control seizures, reduce brain swelling. There is no antiviral drug proven to stop Nipah replication. Healthcare limitations: many outbreaks occur in rural areas. Resource-limited hospitals, settings without IQ access. These factors combine to create a perfect storm. Environmental and climate factors. Nipah outbreaks are closely linked to environmental disruption. Deforestation forces bats to move closer to humans, reduces natural food sources. Climate change alters fruiting seasons, changes bat migration patterns. Urban expansion increases human-bat contact, creates new spillover zones. Nipah is part of a larger pattern: emerging diseases linked to environmental imbalance. Nipah versus COVID-19 key differences. Let's clear confusion. Feature R: fatality rate of Nipah is 40-75%, while COVID-19 is 1-2%. Transmission of Nipah is through close contact, while COVID virus is via airborne. Spread speed of Nipah is slow, while COVID is very fast. Vaccine of Nipah is NONE approved. And COVID has multiple types of vaccinations. Pandemic potential of Nipah is low. High. Nipah is deadlier, but COVID-19 was more contagious. This distinction is critical. Myths and misinformation. Myth: Nipah spreads through air like flu. Fact: requires close contact. Myth: eating any fruit causes Nipah. Fact: only contaminated fruit products pose risk. Myth: Nipah is new. Fact: it has existed for decades. Myth: nothing can be done. Fact: early detection saves lives. Misinformation can be as dangerous as the virus itself. Global surveillance and preparedness. International organizations now monitor Nipah through disease surveillance networks, sentinel hospitals, wildlife monitoring. Genomic sequencing. Countries like India and Bangladesh have rapid response teams, isolation protocols, public awareness campaigns. This is progress, but gaps remain. What a future Nipah outbreak could look like. Experts model future scenarios. Best case early detection. Rapid isolation, contained outbreak, worst case delayed diagnosis, hospital transmission. Regional spread preparedness determines the outcome. Final warning and hope. Nipah virus is not a movie plot. It is not a rumor. It is not a future threat, it is a current reality. But there is hope. Scientific research, vaccine development, improved surveillance. Public awareness. The world has learned painful lessons. The question is, will we apply them in time? If you found this report valuable, like this video. Share it with others. Subscribe for verified health awareness content. Because awareness is prevention. Stay informed. Stay safe.